And those in the audience, today is our monthly county commissioner, Central District Health Board of Directors meeting. This time I'll call the meeting to order and we'll have roll call. Dr. Ryan Cole.
Present.
And we have a vacancy for the other board member from Ada County, Dr. Jane Young.
Here.
Commissioner Clay Tucker. Here. Betty Ann Middleton, Elmore County.
Here.
And Commissioner Rogers.
Here.
Okay, please note, it looks like we got a full board, so other than our vacancy, we will move on. And at this time, I would like to start at one end to the other and ask everybody to introduce yourselves, just for the record. You go first.
I'm Maria Ortega. I'm the Marketing and Communications Manager for Central District Health.
Thank you.
Jan Sylvester, member of the public. Jennifer Walt, member of the public.
Jim Walt, member of the public.
Stephanie Myers, Division Administrator, Family and Clinic Services.
Curtis Lovelace, Division Administrator, Community and Environmental Health.
Courtney Kelly, Project Coordinator for Witch Seed.
And Dr. Greg Furch, nominee to fill that vacancy.
Good. Well, welcome everybody. This time we're going to talk about the agenda, and before we approve the agenda, I would like to add one thing, not as an action item, but as a discussion this morning on the process of counties electing a board member to the Central District Health Board and how that process kind of works, and get some feedback and feeling from everyone here, how they feel about that. There's so we can do that wherever you wish to put it, Donna. Do you want to put it before public comment? Okay, so I need I'll make the motion that we add that to the agenda. May I have a second?
Second.
I'll second. This is Betty Ann.
Thank you, Betty Ann. We have a motion second. All in favor, please say aye. Aye. Motion carries. So that is, how are we going to title that?
Just say election.
Election of board members. Okay.
I would say county commissioners, because the board doesn't approve it.
Right. Election of board members by county commissioners. I think it's important that everybody kind of gets on understanding how that works. You need to go. I thought he did. Okay, we got a motion second on. I did. Good night. All in favor, please say aye.
Aye.
Motion, those opposed? Motion carries. Okay, we're gonna go right on down to our next agenda item, which is a discussion and a vote on our August 18 minutes. Everybody get a chance to look at those. Everybody's good. I'd entertain a motion to approve those.
Motion to approve. Dr. Cole.
Okay, we got a motion on the table. Do we have a second?
Second.
Betty Ann, second.
So we got a motion by Mr. Rogers, a second by Betty Ann. All in favor, please say aye.
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 Aye, motion carries. Okay, we're gonna get through this one pretty quick today, and I'm trying to slow it down because I went too fast last time, so. We take a 20-minute break. Okay, our next agenda item is a discussion on the 2023 Greater Treasure Valley Community Health Needs. Becca, are you here? Curtis is gonna do it?
Chair, I'll be presenting today. Becca is unexpectedly not able to attend.
Great, thanks, Curtis. So you're up.
All right, thank you, Mr. Chair. And I'd also like to introduce Courtney Kelly, who is our project coordinator for the Western Idaho Community Health Collaborative as well. And so in your packet, you should have a presentation that outlines the slides that we'll be looking at today, so you can follow along with that. I invite you to ask any questions along the way. Those questions most precisely can be answered by Courtney, as she is the expert working in this project on a day-to-day basis. So I'd be happy to invite you to ask those questions and defer to her to respond to that, but I'll be walking through the presentation. So
Okay, thank you, Curtis. Welcome, Courtney.
All right,
Go ahead.
Mr. Chair, thank you. All right, so in 2023, we are currently working on the regional and district health priorities. This is a collaborative action between 10 counties in Western Idaho and a variety of community partners. Today, we want to talk about the background and the role that Central District Health has played a little bit. Dustin, go ahead and go to the next slide, please. The background and the role that Central District Health has played, as well as the community health needs assessment that was conducted and has been carried out, and the information that we've obtained on that assessment. We'd like to talk for just a moment about the Idaho-Oregon Community Health Atlas that has been developed and designed and implemented that is helping to provide data and insight into the health status of many populations throughout the area. We'd also like to discuss the regional health implementation plan that we are currently in the process of developing, and discuss with you briefly the proposal that CDH would be involved in, and how CDH would support that proposal and that implementation plan based on the community health needs assessment results. Next slide. So some brief background on this. This is a multi-sector public and private partnership. It was established in 2019. We have a diverse membership group representing public health, healthcare, social services, and many different members of the public. And we are looking to address the social influencers or the social determinants of health within the area. You can see on the map there that we're consisting of the 10 western counties of Idaho. This includes the 4 counties of Central District Health and the 6 counties of Southwest District Health. Together, those 10 counties comprise over half the population of the state of Idaho. So we're looking at a large portion of the population, as well as the geographic area of Idaho. It contains very diverse populations, everything from urban, suburban, rural, frontier, all different types of cultures, ethnicities, and groups within that. And we are looking to address the social determinants of health influencing all of the risk factors and affecting all of those different populations in all those different settings. Next slide, please. This is an indicator of the funding partners and our community partners that we're working with currently. If you look at our current values, one of which is partnership, we are working extensively with a multitude of different partners and working to ensure that we are working across the board with both public and private entities, healthcare entities, social service entities, and those that are interested in the general health and well-being of the population within the 10 counties of Western Idaho. Next slide, please. And I'll also just include that all of those partners that were displayed on that screen are contributing financially towards this Western Idaho Community Health Collaborative and participating as part of the funding council. This slide really represents some of the unprecedented regional initiatives that we've undertaken. This is the first ever regional assessment covering over half of the population of Idaho. It's been groundbreaking in the partnerships that we've been working to develop. And it includes both the health districts and the multiple health systems that are represented in the geographical area. As I said, this is including the 6 counties of Southwest District Health, the 4 counties of Central District Health. It includes all of our major hospital systems, all of our major health insurance plans, and all of those that are interested in the health and welfare of our populations within those counties. We share unique needs across this region as well as unique populations, and working with the same groups of people and individuals. And the great part about this collaborative is that we've all come together and we are all working in sync together. Oftentimes we find that each of these entities alone have really great initiatives and are doing really great things on their own. One of the things we're trying to do is really sync the timing of all of these initiatives so that health plans, health systems, public health districts, counties are all working simultaneously in sync together to achieve the same common goals and outcomes that we otherwise would be trying to achieve individually on our own. Next slide, please. One of the great things that has been going on has been collecting data. Without great data, it's hard to make good decisions. And so one of our primary purposes has been to collect data and use good methods to do so, and then use that data in our decision making. We've collected lots of demographic data and translated that into multiple languages as we've experienced that throughout the counties. We've developed focus groups. We've looked at specific focus populations. We've been in every county across the 10 county region. And we've developed key informant interviews with specific groups, diverse populations. And again, we've gone through every county and every community to make sure that we're covering all of those different bases that we're trying to address, both urban, frontier, rural, and everything in between. We didn't want to leave anyone out. And
Do you mind if I make
yeah,
a
please
clarification quickly?
do.
So this initiative is the creation of the community health needs assessment in this region. It's the first time that a CHNA has been done collaboratively. So generally, each of the health systems would do their own. And for the first time ever for this region, it's all been together, which is a huge deal, saves a lot of resources, and is a lot more accurate for the types of populations we'd like to serve.
So Courtney, is the questions kind of the same for everybody that they used for the interviews?
Yes, all the questions were the same. Data collection was consistent, yes.
Thank you.
Yeah, and so yeah, this data collection is for specifically the community health needs assessment.
Thank you, Courtney, Mr. Chair.
Yes, good.
All right, and that is a really great important part. I think one of the fantastic parts about this collaborative is, as Courtney has explained, it really helps bring all of these different entities who would be doing this individually themselves and helping us coordinate together so that we're not expending resources, duplicating services, and trying to repeat and step on the toes of every other organization that's also trying to do that. We're trying to work collaboratively across the board, across counties, throughout this part of the state to ensure that we're maximizing and being as efficient as possible with the limited resources that we have, with the staffing that we have, with the information that we have, and trying to figure out how we do that in a coordinated and precise fashion. Next slide, please. So as we've gone through this process of the community health needs assessment, we've gathered a lot of information, and we've looked at what are the top priorities that have been identified amongst the population in these 10 counties as the most impactful things that need to be addressed by a collaboration like this, and what would be the most impactful to the overall health and well-being of the population in this part of the state. Those things that were identified are unsafe, unaffordable, or unattainable housing and homelessness, mental health and substance misuse, as well as limited access to healthcare, primarily emphasizing in dental and vision care, along with several other components that go along with that, such as language barriers with accessing healthcare, transportation barriers that exist in accessing healthcare. And those really become the top 3 priorities that have been identified through this information gathering and through the community health needs assessment that has been conducted. So the next question is then, what do we do to address those top priorities and continue to identify additional priorities that we then have the capacity to assist with?
So Curtis, quick question.
Yes.
Would you say that the unaffordable housing is probably priority number 1 and then mental health is 2? Because it seems to me like everything that I've read, it's all tied into if someone has a home or not. If they don't, then they get into mental health and substance abuse, and it just spirals out of control. So unaffordable is kind of the first one, most important one, I should say.
Mr. Chair.
Yeah, good.
Absolutely. So I think these are in order of which the community health needs assessment has indicated they are the priority. So with unsafe, unaffordable, unattainable housing and homelessness being priority number 1. The next slide, please. So going into that just a little bit further into detail, across all 10 counties, in all of the focus groups and interviews that were conducted, there was consensus that housing was the top issue. There was no question or concern about that. That was clearly identified as the top issue. Through these focus groups and interviews, different groups spoke about the need for all aspects of housing, including supportive housing, assisted living, senior housing, workforce, affordable housing in all aspects, working through the issues around homeless and homeless housing and housing the unhoused population as being the top priority. So that is what has been identified through this community health needs assessment as priority number one that needs to help. And as Chairman Hasbrook has pointed out, that without the ability to produce and sustain housing for individuals, it leads us down many other roads of other issues that then have to be addressed that become quite expensive and costly to our communities in other forms. So the community health needs assessment has been pretty precise in identifying housing as the number one issue. Next slide, please. So you can see here, these are some of the results of the community health needs assessment in terms of quantifiable data. You can see in the bar charts going across there, upwards of 60% of respondents identified housing costs and other issues associated with owning or renting a home and having stable housing as being the primary concern that they experienced, which led to a host of other problems regarding their general well-being and overall health. Next slide, please. This one is a little bit more related to the behavioral health side of things. You can see again, upwards of 60 to 70% identifying mental health and that access to mental health or the gaps in mental health care services as being a major issue to the overall well-being and health of the populations in these counties. Specifically looking at different themes of youth mental health, lack of providers in mental health, the inability to get in to see providers for mental health concerns. Next slide, please. Access to care is also another major issue that is being identified. In specifically looking at those things that I mentioned earlier in vision and dental care services, not only are they more scarce, but they're also harder to get into, especially if you have insurance or lack of no insurance or insurance such as Medicaid coverage that is more difficult to find providers that will accept and take that. It does provide barriers to accessing appropriate care for those services. Other barriers that have been identified through the community health needs assessment were language barriers, transportation barriers, and then just hard to receive and afford care across the board for general health care. Anything from prescription drugs to finding the right type of specialist to treat your physical or mental or behavioral health. Next slide, please. Other important findings that came out of the community health needs assessment that were also scoring very high, but not necessarily in the top three, were things such as the cost to access childcare, also being a prohibitive factor in people living healthy and successful lives, the transportation costs and barriers associated with transportation, especially in rural communities where distances may be further to travel. Opportunities for travel may be more limited and the cost to do so may be increased. And then just that intersection with housing, jobs, and transportation. It's hard to maintain a healthy lifestyle when you're constantly trying to figure out how you're going to transport yourself to a job that may or may not be stable, which is even more difficult when you're not sure where you're going to end up for the evening as you're unstable in housing situations. So those all tend to be major themes that implicate poor health outcomes and are major social determinants of health that this community health needs assessment has identified and that our action plan will begin to address. Next slide, please. One of the great things that has occurred through this health collaborative is Alexis Peering, our program manager with this program, has secured specific funding that has helped the development of the Idaho-Oregon Community Health Atlas. It is a tool, it's an online tool that has been developed and implemented to help us utilize the data that's being collected. One of the great things about it is that it's entirely grant funded and has been put together by over $90,000 in grant funding to help create, build, and implement this. And then one of the great things about this is that you can use it, you can go out online, you can use it, and you can start to look at the counties individually or groups of counties or portions of the state, and you can start to look at different things like homelessness rates, rates of misuse of substances, tobacco use rates. You can start to pinpoint different populations or areas of where things need to be addressed, or different populations that are experiencing different health disparities. And so this has been a great tool that's been developed to help us identify specific populations and specific geographical areas that we could focus efforts into from the collaborative to continue to move forward with this. And Courtney, I don't know if you have other ideas or things you'd like to share about with the Idaho Oregon Community Health Atlas.
Yeah, I would encourage you all to go check out the atlas online, free to just access. And it is, in my opinion, one of the easiest to use atlases that I've been able to use. I think it's very clear, very direct and laid out. And I've already been using it in my work specifically I work in Elbert County primarily, and I've been using it as a tool to guide what I'm doing. And I know community partners have been using it already in their work. Frankly, something I wish I'd had in grad school would have made my life a lot easier, but it's very easily accessible, which I think is important when translating. I mean, the CHNA is 115 pages and not very user-friendly necessarily, and this takes that information and makes it user-friendly for our community partners.
And I would just add, it's very visual. It's very graphic. It's map-based. You can look at specific counties. You can really narrow in and look at very specific and focused groups or different social determinants of health. You can make it as specific or as general as you'd like to. And I, again, would encourage you to go out and take some time to look at that if you'd like to. And it does cover everything from Eastern Oregon all the way down into South Central Idaho. As you know, this is something that we're looking at in partnership with some of the health systems that we are working with, which include geographic areas that expand into those areas. And so it includes much more than just even the 10 counties of Western Idaho and the 4 counties of Central District Health.
First, are other districts in the state doing this same thing, like North Idaho? The reason I ask that is because if we wanted to go to the legislature and say, hey, we want Medicaid or Medicare to start covering this particular practice, we're going to need a statewide push for that instead of just from our area. Do you know? Not yet.
Not that I know.
So, Mr. Chairman, I believe that there are some efforts in different areas of the state that may be starting to head towards something like this, but nothing that is as developed or refined as what has been created by the Western Idaho Community Health Collaborative. I know in Northern Idaho, there are other healthcare collaboratives and community collaboratives that are working together to also address social determinants of health and other aspects of the healthcare system and the overall general well-being of populations in those parts of the state. But I'm not aware of anything that is as developed, as has as many partners partnering together and contributing and funding as what the Western Idaho Community Health Collaborative is doing right now.
Would we have access to their data? Do you know?
Mr. Chair, I believe that is something that in the long run makes a tremendous amount of sense, that we would then start to link these community health collaboratives together in a larger network of a statewide collaborative and share that data across the collaboratives in an effort to make sure that all parts of the state are receiving the same high quality partnerships from all the different various healthcare entities that are investing dollars and time into improving the overall health and well-being of the citizens of Idaho. That absolutely makes sense.
Well, I kind of have a sneaky feeling that we all have similar problems throughout the state. And I'm just wondering if this is something for the executive council to maybe talk about in their next meeting. How do we put all this data together? Or maybe it's something the district directors need to do. But if we come at it from a statewide perspective using that data, I think we'll have a lot more luck in the legislature as far as what they're going to cover and what they won't. Makes sense to me, but is there going to be a point where we can say, okay, I'm going to say, for example, our daycare inspections, we need more daycare. So can we make that easier, cheaper, something that we need to do on our part to help assist with that issue or that problem? Are we going to get to that point? Is that kind of the goal at the end?
Mr. Chair.
Yeah.
Absolutely, that is the goal and the point of putting this type of collaborative together. And specifically, that is the goal and the point of having this type of an atlas available so that we can pinpoint and hone right into, say, Valley County or Boise County and say, we're experiencing an issue with childcare in Boise County, specifically in Horseshoe Bend. What do we have currently available within the county? What are the gaps that we can identify? And what are the resources we have to address those gaps? And then how do we work collaboratively as the Western Idaho Community Health Collaborative to address that need?
We tried to put together a daycare center in our senior community center in Cascade and went out for a grant. We didn't get the grant, but the issue we have is to bring the facility up to code was $500,000. And that's to me is the big issue, because you have to have really a legit sized bathroom facilities for little kids versus a regular sink and a regular toilet. I mean, some of the rules I think we got to be a little more flexible and forgiving on until we can get something established. But people are afraid to take it on because there's too many rules to run a daycare. And I think there should be some rules, but
Well, I mean, I could speak to that a little bit. I think the biggest problem is good staffing,
which is probably what salary.
salary, and just people that, I mean, it takes a certain person if you want to have quality staff.
Yes. Well, I agree. Okay, thank you. Continue.
Thank you, Commissioner Rogers, Chairman Hasbrook. Yes, and childcare is also near and dear to our heart, especially in the Division of Community and Environmental Health, as we do childcare inspections. We have staff dedicated to that, and it does take special people to participate in both the rendering of the service as well as the oversight and inspections that occur to ensure the safety and well-being of children and their caretakers as well. So thank you for bringing that up. Okay, next slide, please. So the next question then really becomes, what do we do with all this data? We've collected all this information. We know all this information about the populations that live in our communities. What do we do then? So the next step really is to develop an implementation plan. And what is a regional health implementation plan? Really, it's an action plan that explains what the organization will do to address those community health concerns that have been identified. In this instance, we're talking about a 3-year plan that will be linked to addressing the priorities that were listed and identified in the community health needs assessment. So going back to those priorities were, again, housing, behavioral health, and access to healthcare. So we are in the process now of developing plans that will be agency-driven, community-focused, and anchored with the collaborative and the entities that are participating in our partnership within the collaborative. And by collaborating on this shared plan, we'll be able to coordinate activities with other partners and reduce the gaps that we have identified and increase the impact of our outreach and our combined resources to be greater than what they would be had they been expended on their own. Next slide, please. So what does the implementation plan look like? You can see this process here. You can see where the star is at is kind of where we have landed as of now. We started by just bringing the collaborative together. We completed the initial assessment and mapping of the gaps and the data. We've hosted several different Western Idaho Community Health Collaborative workshops to develop strategies into plans. And then Courtney and Alexis and those involved in the collaborative have been completing interviews with participants, with members of the collaborative, with other entities in the community to identify strategies, talk about ways that we can work together, look for resources, and develop a plan and put that together in a way that will be comprehensive and helpful to all of the different populations that we're looking to serve, and that can be implemented by all of the different partnerships within the collaborative. We are in the early processes of putting that plan together, and by early November, hope to have our first draft of that plan ready for review with a finished and published draft by mid-November. So we are in the process of putting that together now. And Courtney, I don't know if you have any additional insight you'd like to share on kind of the process you've gone through to develop that plan.
Yeah, I think The beauty of WIC in general, and I think the great thing is that it brings all these partners together, and great to collaborate on the CHNA, but if we're not collaborating on our efforts to take that data and move forward, then that was all for naught, really. It's taking all these partners and seeing who's everyone's strengths, what can you accomplish, how can we support that, and making a really comprehensive plan as a collaborative to improve health. Yeah.
So Courtney, is the gaps analysis, is that on the Atlas page? Kind of shows us what the priorities are, so to speak.
I'm not sure if that is on the Atlas per se. I believe that would be within the CHNA, but Alexis would know
I'm
better.
interested to see what those are.
Mr. Chair. If you're interested, we'd be happy to provide you with the 117-page community health needs assessment documentation
Well, that'd be
and outcome. Anybody's welcome to read that.
Do it electronically?
Yeah, we can get that to you and to any board member that would like to, anyone that would like to read that. It has all the text version of all the information that's been collected, the data that's been identified. And you'd be welcome to be able to have that and look through that. The Atlas is kind of a compilation of all the data points that have come together as a result of that. But if you're actually just looking and reading through the text version of it, you can absolutely have access to the community health needs assessment outcomes.
And is that broken out by county too as well?
It's not broken up by county within the CHNA. If you wanted county-specific data, the Atlas is a great resource for that. Yeah.
Because I know we've just talked about transportation issues here and even on county levels like in our area, it's Mountain Transit, I think it's the bus line that the county's funded. I think it's over 50,000 a year to keep those costs $1, $2 to ride the bus to wherever you gotta go. The issue is, of course, it's maybe only twice a day, once in the morning, once at night. So people have to sit around and wait. So we're looking at how can we do a shift in the middle? And that's all, a lot of that subsidized county funds, but I think I'm interested to see how that's worked for Valley County. If it is, it's because I know they're full, everybody's using them. So that's one thing to look at that I'm interested in.
Great.
Okay, thank you.
Thank you. Next slide, please. So the proposal for Central District Health and the role that Central District Health can play in this. Let's talk about that for just a moment here. Again, going back to the three priority areas that have been identified through the community health needs assessment, being housing and homelessness, behavioral health, and access to care. There are specific things that Central District Health can participate in as a collaborative partner that we would like to be a great partner in working with the other entities within the collaborative to assist them. So some of the specific things that Central District Health would be doing, we'd be looking to coordinate internal public health data and provide reports on land use and housing markets and other public health related costs and outcomes related to housing and how it's affecting healthcare, health and well-being, and what that overall cost is really starting to look like based on the housing, the unattainable housing or unaffordable housing that we're experiencing, as well as participating in opportunities to learn more about funding opportunities through either other state agencies or other things that are occurring in other states where wraparound services are being identified. I'll share briefly in some states, they have started the development of what are called 1115 Medicaid waiver services. These are specific services where Medicaid funds are dedicated through these waivers to help assist with wraparound services to help promote stable housing, with the idea and intent that if these Medicaid funds can help provide wraparound medical services that will stabilize someone's health, it allows them to then continue to work in jobs that then continues to allow them to have and afford stable housing, which then continues to keep their health at a better point so that they can continue to work and have housing and have a job. And it just gets better and better as we can provide that type of wraparound service to individuals. And we've seen states such as North Carolina who have worked to implement some of these 1115 Medicaid waivers for these types of wraparound services and access Medicaid dollars to assist with that have then seen reductions in healthcare costs because of the upfront money they put into the wraparound services specifically tied to housing. That is something that the collaborative would like to look more into, research and understand better, and work across the state with our partners for the possibility of developing something similar within the state of Idaho.
So Curtis, quick question on the waivers, because I don't know much about them. Are they for a short time? Are they limited? Are they for life? How does that work?
Mr. Chair, so I do know a little bit about this. Typically, an 1115 waiver is requesting an exception to the overall state Medicaid plan. They typically will either be part of a demonstration waiver or a longer term waiver, but they typically are termed in the number of years that they're available. Now, that doesn't mean that they would end. It just simply means that the paperwork to renew it would need to be done, and all of the data that would need to be submitted to typically the Center for Medicare and Medicaid Services would need to go through that process to determine cost effectiveness and feasibility, and that it's still a good use of Medicaid dollars to proceed with that type of a waiver and exception to the state Medicaid plan. So that we're basically what has to happen is they have to show that they're not spending more money than what would have been spent otherwise. And that's the intent of a waiver, is to reduce cost and to increase access and availability of different services. And so if we can increase the availability of different types of services that then drive down cost, you're showing the effectiveness of the waiver, and the federal government and the state legislature then would continue to approve that waiver.
So it sounds to me like if you're going to say do it for housing, can you get a waiver for housing, funding for housing?
So the way it would work, in my limited knowledge of that, would be that you would develop an 1115 waiver with a group such as Medicaid or another funding source that would say, hey, we're going to make an exception to the traditional rules of how this funding is used. We're going to use it for these other things, such as these wraparound services for housing. In turn, then that is going to help drive down the cost of overall healthcare, and Medicaid, an entity such as Medicaid, would then spend less money on healthcare because they've spent some money on stabilizing housing, which then reduces the use of behavioral health services and other medical services and other things that cost a lot of money because of the lack of stable housing. Or we invest a lot of money into behavioral health services and substance misuse, because we know that that drives the cost of other healthcare costs and problems that then we have to address down the road with corrections, healthcare, and other things. And so if we can invest upfront into the prevention of that, then we can eventually get to a point where we drive down the costs on the back end of the treatment for that. And it becomes over time, with the right data, we can be able to show that it becomes a cost-effective way to spending the resources in a way that will help to save money overall in the long run.
So I'm assuming then is if we prove that a Medicaid waiver works, but then you would go back to the legislature and say, you guys need to make this permanent because it saves so much money. Is that kind of how it works?
Mr. Chair, yes, in a roundabout way, that is one way to do it. Those waivers are also governed very heavily by the Center for Medicare and Medicaid Services, the federal government. They're a key component in managing and governing the way some of those dollars are administered throughout the state. And then the state legislature also has its role in appropriating and making sure that those are being spent in accordance with state and federal regulations. All of those aspects of it would need to be addressed, and that would, one of the roles that Central District Health would play would be to really help do the research, the invitation, and the research and investigation into how other states have done that and been successful, and what infrastructure Idaho needs to put in place for Idaho to also be successful with that, and then getting the right people to the table to have those discussions and share that information and get that ball moving forward.
That's interesting, because I know the state, I think it was 2, maybe 3 years ago, came out with another change in the tax laws where counties can offer a developer to build 5 or more rentals or employee housing, usually deed restricted housing. It's called a 602NN, where basically the first year they only pay them 10% of the value of property taxes. Second year it's 20%, and then after 5 years they pay. So that first 5 years you get a huge break on your property taxes. So encourage that kind of development. And we've done one in Cascade for 17 units. There's another one in Donley that just got approved a couple of weeks ago for 320 units. And that one is going to get some federal breaks as well. Deed restricted based on income, 60% AMI, 80% AMI. And the interesting thing is there's a lot of folks, of course, they don't want it in their backyard because they don't like that kind of housing. But I think where we approve this is going to be a great spot. It's in Donley. And it'll be a couple of years before we see things built out, move. But that 602 and N to me is a great idea because the county isn't receiving anything for that value until they build it. And then we're just saying we're going to wait 5 years and then to encourage them to build it. And it's working pretty well. So that's some things that comes out of the legislature that helps everybody.
We did the same thing in our county for development.
Yeah. And you can only use it for residential, you can't use it for commercial or anything else. So we're going down the right path. I guess we just got a little further to walk.
Yeah, and Mr. Chair, I think that is exactly the role that Central District Health, along with our partner at Southwest District Health, can play in helping to research and identify those types of opportunities that will be beneficial to counties and to the region in providing a more stable housing supply that is affordable and attainable for the populations that we're working with. And I think that is exactly the role that Central District Health would be looking at participating in. Next slide, please. Okay, so this gets a little bit into the proposals for the Central District Health role. And again, we're looking at strategies that will be grant funded and others will be needed to be funded by some of our partnerships that we've developed within the Western Idaho Community Health Collaborative. A majority of the funding that we're working towards is very grant funded. And so we continue to look for and exercise those opportunities every time that we come across them and they're available. We are looking to ask the board and requesting the possibility of allocation of $50,000 in district dollars to support the implementation of these strategies. And so what I think that looks like is that we would allocate $50,000 of district dollars to the Western Idaho Community Health Collaborative in partnership with all of the other funding and contributing partners to be able to continue this process and carry out the action plan that is in development right now, with the specific role that Central District Health would continue to provide that research, the opportunities to develop new strategies and really provide project coordinators such as Courtney the opportunity to go to every county and participate in those county forums to identify strategies, possibilities, and ways to move forward in addressing these priorities that have been identified with the community health needs assessment. This $50,000 would be a contribution to the Western Idaho Community Health Collaborative in a way to continue to participate as a fully vested partner, to be seen by our partners as fully working towards the goals that we've commonly identified as our top priorities. So that is really about the Western Idaho Community Health Collaborative. That is the role that Central District Health is looking to play and participate in, and what we intend to do moving forward with your support. And we'll stand for any questions. And if you have anything specific you'd like more information on, please let us know. And Courtney and I will do our best to provide you information. If we don't know right now, we would be happy to research it and get back with you quickly with the information that you're looking for.
Just one
This
question.
is Betty Ann.
Sorry, go ahead, Betty Ann.
Yes, I have a question. We have brought this up in previous meetings, and I was just hoping that there is some way that we can, housing is going to take a long time. In between Magic Valley and Treasure Valley, our rural communities are really experiencing a bulge of people who are looking out of necessity for a lower cost of living area. We don't have the access to care. We don't have the providers that you've addressed. And particularly like in Boise County, we have no primary care services. We did ask for a mobile situation to be addressed, is there any way that we can fast track that a little more so that those people are getting some primary care services?
Mr. Chair.
Yes, go ahead.
Thank you, Betty Ann. Appreciate your comments on that. And yes, those are priorities that have been identified and we are currently working to address as well. We are currently working to develop and obtain the mobile medical unit, something that we could then utilize to enhance our ability to offer services in rural communities. That is something that we're currently working on and engaged in at the moment. I think fast tracking any of these priorities or any of the strategies that are identified in our action plan is something that we want to look for and take opportunities every time that we can. And I think that's exactly what our staff are looking for opportunities to do. So I think when we talk about our health policy and promotion team specifically and the work that they're engaged in, looking to fast track any of those strategies is exactly what we want to be doing. So we appreciate your support in that and thoroughly agree that fast tracking any of those action items that we can take from our community health needs assessment and implementation plan is the right approach. And we appreciate the board's support in helping us to achieve that.
So Curtis, is there like a cost that's going to be for the mobile part of it? I mean, have we kind of put together some dollars about what that would take?
Yeah, Mr. Chair, we're currently in the process of researching that. We've got some meetings scheduled with some vendors to help us identify and nail down exactly what kind of costs we're going to be incurring. I know in previous board meetings, we had set aside specific dollar figures to address a mobile unit. And we are continuing to work through that process and work with vendors on getting and following our purchasing policies on quotes and obtaining all the information necessary so that we can make the best decision with good information. And we're working through that process currently and making progress as we get there.
So how do you see that? Is that going to be more like a contract with somebody that does that, or is that going to be something we're going to build ourselves?
I can answer that, Curtis, if you don't mind, or if you'd
Great,
like to. So we have a meeting scheduled with one vendor early next month that does custom builds of pre-built medical mobile vans. We decided that was a better option than buying a van using the state contract and then adding all of the modifications. The state contract didn't have any that were pre-built or even ready to add the customizations that we want. So we have the vendor right now that we have the meeting scheduled with that does the custom builds. They will provide a quote to us based on our needs. Once we get that quote, we'll get at least two other quotes from different vendors, assuming they can do comparable custom builds. If we can't find two other vendors to do the comparable builds, then we can do a sole source with the vendor that we have that meeting set up with. But our first attempt will be to get at least three comparable quotes from vendors that do the custom builds, and then we'll be able to make a decision from there. We should have that number before the December meeting, so we can give the cost to you, the estimated cost to you then, and we should also know whether or not there are vendors that can do comparable builds. So potentially by the December meeting, we may be asking for additional allocation of funds for the van. I know we talked last meeting that it more than likely wasn't going to be enough for what we're requesting. So by the December meeting, we should have a built out quote to bring to you, know if there are other vendors that can provide a comparable build, and know whether or not we would need to ask for the allocation of additional funds. So that is very close on the horizon.
I think this is awesome, especially for our geriatric group in the world, because they're not able to get to doctors. And Laura, I want to ask you the 50,000 to implement this. Did we budget for that?
We did not put that specifically in the budget. Last year, for our reserve fund designation, we had asked for that, and it was requested that we put what we'd asked for back in the undesignated reserve during that special request time last.
Will you remind me, how much do we have in that? Isn't that
We have a healthy
2 million
balance.
or something
Yeah,
like that?
we'll be going over the financial,
Good.
or our designated fund, I believe, had just under 500,000. And this would be something we could allocate for, which we have the balance there to do it. The question would be whether or not you want to. It's not an action item on the agenda today, so I would suggest that if discussion warrants support of that, we would put that on the December meeting agenda as well as an action item.
Well, then I'm going to go ahead and ask how the rest of the board feels about that. Is this something you guys want to pursue? Is this something, the 50,000 plus maybe some future costs as far as a mobile system set up? I'm assuming that we're probably going to buy the wheels and tires, and then other groups like St. Luke's or St. Al's will probably be part of the staff. I don't know how that's going to work, but if we all work together, we provide the wheels and the grease, and they do the personnel. How does the board feel?
I guess I have a question on the allocation. What is asked of the other collaborative partners as far as dollars go?
As far as, Mr. Chair, Commissioner Rogers, yes, all the other funding partners are contributing. I don't know the exact dollar figures that they will be contributing exactly, and I don't know if Courtney has more specific details on that, but I can certainly obtain that information and get it to you. But I can affirm that all of the partners are funding and contributing funds to the Western Idaho Community Health Collaborative. It is each of those partners sit on the Executive Funding Council. They are contributing dollars. They have contributed dollars in the past, and we are expecting that they will continue to contribute dollars in the future. And then as part of that funding council, they have the ability to sit and make decisions about how the funding will be allocated and spent as well. And what Central District Health is being asked for in terms of financial contributions is the same as what we're looking at with Southwest District Health as well. And so we would be equally contributing as health districts to that collaborative and participating as full partners with them in both the contribution and decision-making as a partner in the collaborative.
Curtis, this is Betty Ann again. Now, on our funders, I see, the ones you have listed, but this is probably a totally different category. Are we working at all with our HQFCs here locally? We have a huge expansion of that happening in our county.
I'm sorry, with our who?
Our HQFCs.
With our community health.
Our federally funded healthcare centers.
Yep, our federally qualified healthcare centers are integral partners within our healthcare settings, and absolutely are partners that we intend to work with and do currently work with and intend to work with in any capacity that they're willing to and we're able to. I think we've developed some really strategic partnerships with our federally qualified community health centers, and we'll continue to do that. And although they may not be listed as funding partners, such as St. Luke's or St. Alphonsus or Intermountain Healthcare, I think they are integral partners in the overall care and well-being of our populations. And we would love to expand our partnerships with them in terms of having them to participate and financially contribute as they're able to our Western Idaho Community Health Collaborative. I think we see them as very valued partners across the region. We have a number of them.
I think that we already have a mobile set up here in Mountain Home with Desert Sage.
Correct. Most of our federally qualified health centers do have mobile units and are using them as outreach methods to rural communities and for specific types of care to disparate populations. And I think that is a resource that we could tap into and better utilize, and that our collaborative needs to take into consideration when we look at the availability of access to care and how we enhance access to care, especially to specialty care in rural or minority settings.
Thank you.
It would certainly be nice to know kind of how much it costs them to run that program. To give us kind of a general idea of what we're looking at.
Mr. Chair, agreed. And I know as part of our preliminary research in the research that we've done to understand better what we need to do with our own mobile unit, that is exactly what we've done. Is we've gone to those partners. I know specifically we went out to Terry Riley. We looked at their vehicles. We understood what was working for them, what was not working, what things they would like to see different, as we're incorporating that information into our process of decision making as we move through the process. So yes, those federally qualified community health centers are valued partners that we can learn from. They already got a lot of infrastructure in place that we can partner with to tap into and facilitate and create a lower the barrier to access to care to a lot of our rural communities, to a lot of our disparate populations, and really to partner with them in that aspect.
Okay, how do the rest of you feel?
I have a quick question. The funding partners, are they looking at changing reimbursement to providers so that we can have more providers generally? Or is there that conversation going on?
Mr. Chair.
Go ahead.
Changes to reimbursement in healthcare are always an ongoing topic of discussion. There absolutely are conversations from all of the different funding partners on what that looks like. I think there's in the recent years, there's been a large push to move from a volume-based reimbursement strategy to a value-based reimbursement strategy. And I think that is something that the state in general has looked at. I think that is something that our healthcare systems have really bought into and taken a larger approach to. I know specifically from the state's perspective and Medicaid specifically spending, there is a great emphasis on reimbursement structure changes and helping providers be compensated in a way that really reimburses them for the value of their care and the outcomes that are achieved with patients rather than simply the volume that is seen. So there has been great, yeah, there really has been something that's been worked on for years. I'm not aware of exact timelines or specific timelines, but I do know that the state Medicaid system has implemented strategic reimbursement strategies to address some of those disparities, where they've shifted from volume to value. As one example of that, in 2021, 2022, state Medicaid systems shifted to reimbursing inpatient hospital stays based on DRGs rather than a percentage of billed charge. And so that was a major shift in reimbursement structures that changed the way hospital systems were reimbursed. There's been changes in the way the state Medicaid system is paying for primary care and paying more a higher rate in capitated payments to primary care providers who then are seeing patients and providing case management to them and referring to specialists as needed, and then creating accountable care organizations that then group providers together who have agreed to provide care for groups of patients and helping to manage that care and keep the level of health at a higher status so that overall costs can remain lower while patients continue to receive high quality care from some of the best providers that are available. So there are unique strategies that are being implemented across the state. There are unique strategies being implemented by different payers. I know Blue Cross, Blue Shield, Pacific Source have all participated in similar types of reimbursement restructures. I know there are different types of coordinated plans between specifically for our dual populations of Medicare and Medicaid eligible participants, where we are looking to coordinate plans and provide them one coordinated plan that is offered by a variety of different health plans, such as Blue Cross, Molina Healthcare, to go in and coordinate the Medicare and Medicaid benefits in a way that allows them to receive the services that are necessary at a higher quality and at a reduced rate that allows them to continue to receive the best care available in a more coordinated fashion so that they're not duplicating services or having things missed because one or the other overlooked something. It's much more coordinated. So I know that there over the years have been extensive efforts on the state's part to coordinate some of those reimbursement structures, to refine them and to develop them. I think the state has taken a good approach in looking at what other states have been successful in doing, how they have carefully implemented those, taking the best approach that we've seen work well in other states and implementing those, and then fine tuning it to meet the specific and unique needs that Idaho has in terms of the populations that we serve and the resources that we have available and the expertise that we have within our healthcare systems.
Okay, so I'm gonna keep going here. Clay, how do you feel about this 50,000 plus maybe funding for a mobile unit?
Yeah, we talked about that last meeting. I mean, that sounds like a great idea to me. I think
Dr. Cole, are you still on?
Absolutely. Yeah, I remember we discussed this before as well. I think it's a great idea, and I think it's an absolute necessity for the rural communities. I think it's so hard to get providers to permanently stay in these communities, but if we can outreach like that, I'm 100% on board.
Well, it sounds to me like we need to put this on as an action item for the December meeting and decide whether or not to commit funds and how much funds. By then we'll know kind of what the mobile unit will cost, and we can make those decisions then. So the worthy secretary will add that. That'd be great. Okay, thank you guys. Very good job, both of you. Anything you want to ask us? Anything else?
Mr. Chair, we appreciate your support and for the opportunity to present the information. And if you have future questions or need additional information, please do not hesitate to reach out to myself or any member of our health policy and promotion team, to Alexis Pickering, our program manager, Becca Sprague, our program manager, or Courtney Kelly, our project coordinator for the Western Idaho Community Health Collaborative. And again, thank you for your support.
All right, thank you guys. Thank you, Courtney. Appreciate it. We're going to move on down the agenda unless someone needs a break. Everybody good? Okay, we're going to move on into the 9:10 agenda item review and discuss the 24 financial report. Laurel, good to see you again. I'll turn it over to you.
Chairman Hasbrook and the rest of the board and members. This presentation will be relatively quick today. Thank you, Dustin, for pulling it up. So I'd like to start out by reminding everybody that we have transitioned to Luma. May or may not have seen some of the statesman articles and other information that's going around about Luma, but there have been some pretty significant difficulties in getting reports out of Luma. The reporting system is different than what we used previously, and all of the numbers are not showing up in the right categories, and we know that going in. So working with Conan coming into the report today, we had two options. One, to say we can only provide high level expenditures and revenues, or two, to say let's put it in a similar format to what you're used to seeing and know that some of the numbers are off. We went with the latter, not the former. So what you're seeing today is the format that you're used to, but it involved a lot of Conan's time, a lot of spreadsheets of manual calculation that he was able to get out of Luma. So these numbers represent what's in the Luma system, but we know that some of them are miscategorized. So
Maybe what I might suggest is for the December is to have both this report and then what it looks like when it comes out of Luma, and then we can kind of figure.
that was going to be one of the questions I'd ask is, would you prefer to keep the same format? Are there other numbers you'd like to see? Are there things in our financial reporting, in our budget to actual, that you would like to see represented different? We do have the opportunity to change format with the shift to Luma, but right now the reporting function itself in Luma, it's not just that the format is different, it's that the function isn't fully developed and isn't working like it was planned to. So we're not even getting reports out of Luma yet that I can bring the format to compare right now. We are confident that our numbers, if you see our revenue district total of 27%, that number is correct. And then our expenditures total of 23%. Those high level numbers we're able to get, it's where they break down in the categories at the line item levels below that we're off. So can draw your attention to a few that we know are off. Our fees are underrepresented, showing only 15% of where we expect it to be this time of year. And where a lot of those numbers are ending up now, and we just don't know how to move them back to the right categories yet, is in the other category. You can see we're at 54% of where we expect it to be this time of the year. So we expect to see that transition back to the categories they're supposed to be in, but we are confident that we've received about 27% of our revenues compared to the 25% that we expected to be this time of year. In our expenditures, you can see our support services personnel costs are at 35% of where we plan to be for expenditures. That also, for any personnel charges that were not properly categorized or calculated, they all went into the support services category. So that's falsely inflated. And then our operating and support services going according to the personnel numbers is also showing inflated compared to where we know the actual expenditures have been. Again, that 23% overall is accurate, but some of the numbers adding up to that have been miscategorized. And we are hoping by December that the numbers in all the categories will be correct. Page 2 supports exactly what you saw on page 1. Fees are under where we expected to be. That goes all the way down through the total fees. Contracts are showing over where we plan to be. Fees showing 41% under where we expected to be. It's all the same data that was on the first page, just as we were used to seeing it represented different. And now on this page, we get to compare it to the last 2 years as a second reminder that we're off from where we normally are this time of year. Personnel, operating, and capital are showing under, and our TMB is showing slightly over, but pretty close to planned. So with that, and my apologies for the longer transition to the system than we expected, we'll move on to the cash balance statement. You can see that in our operating and LGIP operating, there was some movement of funds, and Conan needed to do that when we initially transitioned to Luma. Some of our balances in those funds were showing lower than what we needed to cover payroll and some other expenditures, so he had to do some movement there. He will be moving funds back into our interest fund as we get a little further into the system, and he can reallocate where things need.
That's $1.5 million.
Yep, that's what that is.
Okay.
So looking at our special projects carryover designation, nothing has been sent on any of those things that have been set aside so far. We do have that 100,000 as a reminder for the van purchase that the board has already set aside. And so, as I mentioned, by the December meeting, we'll have an estimate for you from at least one vendor, hopefully more, on what total cost of a custom built van would be. We did go look at comparable mobile units, areas the board suggested, and we've decided to go with more the van setup than the small mobile home type setup. When we talked to our partners locally, they said there's a lot of issues with balancing them, and they're great because of the variety of services that can be provided from them, but you really want to go to a place for a day set up for the whole day rather than going from location to location, whereas the bigger cargo van style is a lot more actually mobile, and you can plan to be in multiple places in a day more easily. So we've decided that size is the appropriate size for us to start with, and potential expansion from there, but at least as a starting point, the cargo van was the right size for us. Employee retention, that will stay the same until the December, January timeframe when we do the one spend out there, and the environmental health system upgrade still in progress, will be spent during this program year, but we haven't had any expenditures attributed to that so far. No other changes to operational reserves, capital reserves, or other numbers on this page.
So the undesignated is down to 450.
Mm-hmm.
That's where we take the 50 and whatever. Well, we've got 100,000 for the van here.
Yes.
Looks like we can afford it. 117,000 for employee retention. That's on last year's.
That's
schedule.
for this year. That will come out in the first paycheck in January, and we'll use the same structure that we did last year, which is increments of 500,000 and 2,000 based on longevity.
Okay. No, I had one more question. I know the code has kind of changed as far as financial reports. Do you need a motion from this board to accept this? Make sure you're okay.
Good question. No, we don't need a motion to accept this. I think the main thing I can tell you is we'll keep working to make sure that our funds are categorized properly and that they're coming out of the system correctly as well, and we can represent them accurately. From what we've heard, a lot of other agencies, districts haven't even been able to provide this level of detail yet. So I was really thankful to Conan for the time that he spent trying to get to this point. But again, we know that there's a lot more levels of coding of each single requisition item that's charged. So when all of those weren't correct to start with, they ended up in kind of a designated fund that will need to make sure get allocated correctly to the proper funds later. It's been really difficult to learn the new system. We'll get there. Everybody knows that, and transition's a big thing. We're 3 months in, and a leadership role feels like plenty of time. We want it all right away, but considering the scope of the transition for the entire state, it's still really new. And bottom line is we're still learning it.
Well, we're going to do the same thing in the county with new software for county bills and claims and stuff. It's a whole different format and nobody likes change, but change is inevitable.
And there were things we didn't realize in starting what was required of reporting or getting requisitions or invoices to process. Just levels of detail that we didn't have to include before. So getting all that straightened out is that our finance team has really put in a lot of time, our administrative professionals. It's always cool to see everybody come together when they have to and learn new ways of doing business and put in the extra time and work to be able to do it.
And just don't pull out too much hair. Pretty soon you won't have any left, so.
I'll try to, I'll pass that message on to Conan. He's doing the bulk of it.
It's not easy, but it can be done. Okay, thank you. Appreciate that. So does anyone need a break before we go into an executive session? And at this time, I would entertain a motion to go into an executive session for employee evaluation. I believe it's 206B, isn't it? Yeah. Have a motion. I have a second.
Chair, I'll second.
Been moved and seconded to go into an executive session for Idaho Code 742061B. This is to consider the evaluation, dismissal, or disciplining of, or to hear complaints or charges brought against the public officer, employee, staff member, or individual agent, or public school student. All in favor, please say aye.
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 Aye. Okay, those opposed? So we're gonna, let's see, it's 9:41. We'll go into an executive session in about 4 minutes, Dustin. So we'll take a quick break and then come back at 9:45. As everyone knows, you all have to leave the room except for the board members. And then we'll do this will be real easy, real quick, I hope. Okay. Okay, welcome back. We gotta go backwards and start over on our executive session. We have a motion by Jane.
Yep.
And seconded by Clay to go into an executive session per Article 74-206-1B, which is employee evaluation. At this time, I will take a roll call. Dr. Cole,
Present?
Dr. Young,
Jane Young, aye.
Commissioner Tucker,
Commissioner Tucker, aye.
Eddie Ann Nettleton,
Aye.
Commissioner Rogers.
Aye.
Okay, at this time, we have an aye vote to go into an executive session. So now you can, all those in favor, okay, we did that. So now you can turn us off, Dustin. But Okay, welcome back, everybody. We're out of executive. We've got to wait for one more board member to show up. There she is. So at this time, I would entertain a motion from the executive. Who's gonna make it? This is always a challenge. Evaluation.
That's what that was.
We just have to approve the valuation.
That's right. Right, that's your motion you're asking for right now, is the next agenda item.
Okay, part of that evaluation is the decision out of executive session. Okay, so we'll move on to the next agenda item, which is only an hour late. Discuss and vote on the evaluation of the district director. I think we're all really very well pleased with the evaluation. I did have one question for Russ on the survey. Did you get to read those? Culture survey? You do? Okay. Yep. We weren't sure and we thought it was important that you read those. We have discussed an issue with the salary situation over the years, things that we wanted for Russ's compensation didn't get approved by the state, and we've come back and tried to rectify that today. So at this time, I would entertain that motion to fix that issue.
Mr. Chair, I'll make a motion to raise pay to $88.70 per hour. With a $5,500 employee contribution per seat, effective 10/15 of this year.
And moved and seconded. Everybody understand the motion?
Yes.
Yes.
Okay. All in favor by roll call, please. Oh gosh, where's my list? Dr. Cole,
Aye.
Dr. Young, Dr. Commissioner Tucker,
Aye.
Betty Ann,
Aye.
Mr. Rogers.
Aye.
Okay, we have, and I also am going to vote in favor of this. We have a 5-1 vote, so the motion passes. And this is to be effective October 15th, it was a couple of days ago. So you should be compensated here shortly. Thank you. Okay, we're going to keep right on going because got more things to do today. The next one is the director's report to include food establishment license fees and December Board of Health agenda items.
Okay, Mr. Chair, so there's, I guess I'll start with the December board agenda items. We talked about with follow-up to what Laurel presented with the Witch Seed funding for the van and then the $50,000 contribution toward Witch Seed implementation, which Commissioner Rogers, you brought up about what the other partners are doing, and I thought about that, and I want to make sure everybody knows that that investment for any implementation will be 100% for work that's done within our 4 counties. So it's not going to go into a pool and used for potentially for the other health districts. So, and again, we can talk more detail about what the plans are with the implementation component, what Curtis and Courtney had shared earlier. So, so if you have agenda items, feel free to send those to me. If there's anything that you want to talk about, and really anything public health is on the table, you're welcome to send those to me or to Donna ahead of our December meeting. So we can try to get the agenda out, posted about a week ahead of time. The notice that we're going to have a meeting and then the agenda posted. Obviously, we can change that up to including after the meeting starts for information items. So food establishment license fees. So I always say start with, for those of you who've been around, this has been really an ongoing issue, a challenge with how that's structured differently than pretty much all of our other fees where it's set in Idaho code. It's a really large program. There's a significant county contribution to that. It used to be a state contribution, but the share of what some refer to as subsidizing the food establishment industry is coming out of county taxpayers' pockets. So the executive council, which Betty Ann and Commissioner Hasbrook has served on over the years has talked about this. We've been able to raise our fees every 5, 6, 7 years, but it's never kept pace with inflation. And as soon as they get approved, you start losing ground right away because you have fuel costs and salary costs and things like that for staff. So what we were looking to do, I met with, along with Nikki Zog, the Director of Public Health District 3, looking to put together a policy and a formula that would be outside of the process, would be outside of having to go through the legislature every year, that we can get an agreement from. The people we met with were the food establishment lobbying staff, and they seemed agreeable. Obviously, there's a lot between the concept and getting this done to allowing this to happen outside of Idaho code, which would then give our boards, all the boards around the state, all 7 boards, more opportunity to make adjustments to fees in a transparent and accountable manner, at least every 2 years, rather than having to wait. And, with legislation, right, it's an election year, so we're going to wait till the following year. And I think that's a lot closer to what we do here with you guys just approved our policy on fee setting and then approved our fees. And that's essentially what this would look like, but it would be a policy that would apply to all 7 health districts. So still work to be done. Likely the executive council, which I guess I need to look at Betty Ann, will be meeting and talking about over the next couple of months. We're not planning to do anything this legislative session, so it'll come up at the Idaho Association of Local Boards of Health meeting next June. And again, we'll have more discussions about that in the spring.
Sorry to interrupt, but I think it's important for everybody to understand that last year, I think the county subsidized the food fee about 1.7 million.
Yep.
And this year it's going to be probably closer to 2.
That's right. The other thing I was going to mention in terms of potential legislation is under Idaho Code Title 39, Chapter 4, which establishes the districts and responsibilities and budgets and things like that. 39.411C is all appointments of the district board shall be confirmed by majority vote of all the county commissioners of all the counties located within the public health district. So that's how it's set up today. That's how it's been for at least 18 years. Last year, there was a conversations about allowing a county to appoint somebody, and then they automatically basically would get to serve on the board without confirmation from the other health districts. So I'm aware that there's discussions about legislation around that. So I just wanted to make you aware, and we're going to talk about that next on the agenda. So it's an awareness point right now, but if it gains any traction, you all will have to have those discussions, and Betty Ann representing you on the executive council will be the one to weigh in on that on behalf of this board, along with the 6 other executive council members. The last item of legislation, there was a bill printed last year. It didn't go anywhere. Came out of North Idaho, which would allow the counties individually to opt out of funding their health district that they're affiliated with, and presumably establish their own local health department. I had expected that wasn't going to really see the light of day again, but I just heard from one of my colleagues in another health district that there's discussions amongst their board and maybe even an interest by one of the board members, many of them are county commissioners, of revisiting that this year. So that's kind of a big deal. It would disrupt the system that's been in place since 1970 with the district model. So we want to pay close attention to that. And like always, we keep Seth Grigg and Kelly Brassfield at the Idaho Association of Counties informed as we hear these things, so that they can also kind of keep an eye on it and work with the legislative committee of IAC. The last thing I have is we completed our financial audit. So we do those every 2 years. And we will have a presentation from Harris CPAs at the December board meeting, and really great credit to our executive leadership team with Laurel, Stephanie, and Curtis, and of course the finance team. You heard Conan's name come up earlier, and it will certainly come up with the audit. 18 years running, we've never had a finding, and we won't have a finding this time either. So it's kind of a big deal because that helps us with securing funding that we have built up. Our grant writer, he's doing a fabulous job, and you don't want findings when you're applying for grants from anybody, from nonprofits and from the government. So just that's kind of a heads up, one of the additional agenda items for December. That's all I have.
The question, I guess maybe you were for Laurel, did Swigart not bid on it, or how are we doing that audit now?
Harris CPAs was the one that was selected when we went out to bid. We have used Swigart in the past, but they were the selectee. This time, based on the way they bid, some of the peer reviews that had happened with the people who bid. So they were the final selectee for it this year. We will go back out to bid 2 years again when it's time.
You mind, how much do they charge to do it's a 2-year audit, right?
I do not have that figure on the top of my head right now. I remember Swigart being around 30,000.
Yeah. Sure, I think this was around 40.
I believe that's correct.
Yeah.
Yeah.
It's good that there's competition coming into that
Yeah.
process, because, man, it's gotten expensive. I think the counties, ours was 18,000 for the county, and I'm gonna say 3,000 or 4,000 for our EMS. So we're paying quite a bit more than the counties are to have this audit done.
It might be that it's 2 years, or is the county 2
Maybe
years
the
or the
2-year
annual? Be part of it. And also the scope of budget, and with they have to do the individual programs as well, so it could be part of what's in the scope of it.
Well, if you get a chance, maybe sing me over what that cost was, just so I can kind of watch that one thing. Because you guys have to hire, I think it's Swigart that does Boise County.
I was thinking it was Harris.
Was it Harris? Okay. So that's good. New players on the field, maybe it'll get cheaper. To go back and talk a little bit about the issue with how boards are appointed. As you guys know, there's 4 counties, each have 3 votes, and you have to get at least 7 votes in order to serve on this board, which I think is okay. But my issue, and I had this ever since the beginning, it's like, why do other counties get to vote on my nominee? And I've always felt like that this doesn't seem to make sense to me. I don't know if it's the right way to do it. What I do like, I think in this case, is that I think there was 5 other people, Greg, that applied.
Yes, there were 5 applications in Ada County, and then we did interviews and they vetted and made their decision.
Well, and I'm interested to see what the executive council comes up with, but I don't personally, my own personal thing is, as a commissioner, it's like, I don't think other counties should have the ability to turn down my nominee. If that's the case, this is who I want. However, that stated, I think if we're going to do away with that system, there needs to be a process that we can remove people from the board. If 7 of us come back and say, we don't want this board member anymore, and we have a meeting, we have a petition, and we vote on it, and that person is automatically off the board, I think that process needs to be in there as well, which I don't think there is now. So it's kind of coming at it from the other side of the door, so to speak. But to tell the county we don't like your nominee, I think is rude, and we have to respect the wishes of those county commissioners at that time, and that's who they want to push forward. And I don't think that we should have any say in other counties. And I've been thinking about this a long time, but I do think there has to be a way that we can take people off the board if enough of us agree. So Betty Ann and the executive council, if you guys get to that point, I certainly hope you'll consider it.
Absolutely.
And we'll just see where it goes. It may not get introduced, and we might still be under the old system forever and ever. We don't know. But I know the 380 county commissioners are going to push it pretty hard this winter, and we'll see what happens with it. But I hope there's a way that we can not do away with all of it, because we need that ability to remove people as well.
Well, and right now on our district's bylaws, we do have, that is addressed, an absentee, 3 meetings, I think consecutive, that removes you from the board. Am I correct, Russ?
Mr. Chair?
Yep.
Yes.
Is it 3 or 2?
Betty Ann, the bylaws, so if you miss 3 consecutive meetings, then the bylaws direct me as a secretary of the board to notify the chair of the county that appointed that individual that the person missed the meeting. So there's no, you should call it like disciplinary action from that. It would be a notification, and then it'd be up to that individual board of commissioners whether they wanted to proceed with removing or replacing the board member that was absent.
So then the worst case scenario would be, well, so what? He didn't show up. He didn't show up. Pretty soon we don't have any board members. Right. There's got to be a better way that you miss 3, you're automatically out. It's cool. In county commissioners, it's 3. You miss 3 in a row, you're out.
But Mr. Chair, just for clarification, I think that's the direction that you're talking about, is if Idaho code has changed, I guess to make that enforceable, I think it would need to be an Idaho code, not by a bylaw voted on by this board. But maybe something to negotiate or remove this requirement and add this requirement.
Is there anything in the bylaws that talk about like a backup person? What do you call those? Somebody that, an alternate that could come in and take that chair if that board member's gone 3. Is there an option to do that?
Mr. Chair, we don't have that currently in the bylaws. I don't think there's anything to prohibit somebody from delegating that responsibility. Like if you weren't able to make the meeting, you could maybe delegate that to one of your fellow commissioners. I don't know that there'd be that.
Well, it's something for the executive council to chew on through the winter.
Okay.
Okay.
Okay. Got it.
Got it. Okay, we're going to move on down. At this time, I would like to introduce Dr. Greg Perch. Please come to the mic. Kind of give us a little background history, why you're interested in being on the board, and let us get to know you a little bit.
All right. Ooh, mic up here.
That's fine.
As was noted, my name is Greg Furch. I've been a chiropractor in Boise for coming up on 30 years. I've got some additional background. I was an Army medic for 11 years. That kind of diversified some of the experience. I spent a fair amount of time in different Army hospitals, emergency rooms, clinics, driving ambulance. I was in essentially MASH units. I worked with setting up field hospitals and those sorts of things. It kind of has hopefully a distant tie into central district functions. But nonetheless, I found out just a little bit ago that apparently my dad found his way to the Elmore County meeting this morning. I've kind of kept that a little bit under wraps. I haven't made a big deal about that, but he's a retired 40-year dentist, so I grew up with oral hygiene. Apparently we did okay in Elmore County this morning. I don't know if that, with your presence here, Commissioner Rogers, if it's 2 votes or 3 votes or how that worked. What's that?
I will vote when I get back.
Oh, okay, so it's a little delayed. So, I've had a passion for public health, and I think in the application that I filled in for Ada County, they asked the why question. And as I was reading through the parts of the Central District Health website, I saw Russ's dissertation or, comments on there about the mission. And what I told Ada County commissioners is that what he had written there was pretty much a mirror of, I guess I would say, my life's work, going through starting at my 10 years of college education, my continuing ed and the things I've done, and the 30 years in my private office. And when I had the opportunity to be in the state legislature 2021 and 22, I found my way to the Health and Welfare Committee, which is something, of course, that fit right into my wheelhouse. And I enjoyed having that perspective. And I think that's also a bit of a unique insight that I can bring to this board, having had that experience. So that's in a nutshell. The vacancy came up and I thought, oh, it's a very suitable position for what I believe to be my skill set.
And the wages are huge.
Yes. I've been in many a position where those are the kind of wages you get.
Coffee and water.
Yeah.
Coffee and water.
Yeah. And I said it earlier, maybe when I grow up, I'll take up coffee, but not even that so far.
Okay, anybody have any questions for Dr. Burton?
Very good. Well, thank you for letting me be here this morning, even though it's not official.
All right, thank you. Now we're gonna move on down to the section I enjoy the most, the public comment. Is there anyone in the audience that has public comment? Yeah, we have people all the time. Come on up to the mic. Need you to state your name for the record, please.
Sure.
Need the town that they meant to. You need the town, the residents, just their name. Okay, go ahead.
All right, good morning. It's a pleasure to be here. I come today, I think with two items. I'm still debating the last one since the agenda changed this morning. First, in attempting to prepare for public comment today, I realized I was at a handicap. I know it's typical that boards receive a copy of their board packet at least 24 hours in advance of the meeting. For today's meeting prep, I assume this packet for you would have contained the draft minutes to be approved, a summary of the Treasure Valley Community Health Needs Assessment, a summary of the item to be discussed in executive session, which I assume would have been a copy of the evaluation of the district director, and a copy of Mr. Duke's director report. Having a copy of this packet, minus the items for the executive summary, executive session, would assist the public in giving informed public comment or directing us on which way to ask questions and how to be involved. I realize that the minutes from last meeting have not been approved yet. However, a copy with a large draft to be approved stamp could be affixed to the draft minutes until approved, and that would give the general public enough information to ask follow-up questions. I can't seem to find an online archive of the video of any past meeting. So if there is such a thing, maybe somebody could direct me to that. So this summary of the meeting in form of minutes becomes invaluable, especially if those video archives aren't available. Especially since the meeting was held August 18th. The meeting today is October 20th, and my next opportunity for comment, if I had any comment or question on last month's meeting, would not be until December 15th, 4 months from when you last discussed whatever issues that would have been. Regarding other items the public would have access to, it's always helpful to see a summary before hearing it for the first and potentially only time. There were things that I heard during his report that I'm trying to write down, and I don't have access to something written, and I missed something. So maybe I'll ask you afterwards. Meetings before this one today, public comment has been before the full meeting takes place. So the public would not have had enough information to speak intelligently about a topic in advance without those details. Therefore, I respectfully request the board meeting packets, sans executive meeting items, be uploaded online with the agenda in the future so the public can better involve itself. And my second comment, which I'm going to change a little bit, is just from what I had found online and publicly, Mr. Furch had been nominated to replace Raul Labrador by Ada County Commissioners. The confirmation, it's not on the agenda today. It was added this morning, apparently. And an appointment date couldn't be found. And so Ada County doesn't have proper representation today. And so it just seems like you're already discussing potentially a more efficient, less cumbersome system. If you could, just make sure you involve the public in those discussions as things go forward, that would be great. And publish the date that he's going to be nominated or, sworn in or whatever the process is. maybe make that available for people. That would be helpful. Thank you for your time.
Can I get you to give me your name again?
Oh, yeah, sorry, Heather Wenger, Wenger.
And I'm gonna let Russ or Donna kind of answer the question on what's on the website.
Okay, that'd
So
be
I think
great.
most of this stuff is on the website. Maybe we're having
If so, then my apologies to whoever, and I just couldn't find it. I dug around and I found the agenda, no problem. I did finally find the budget, and I was in a different place in the agenda, but like when I went, yeah, so I couldn't find it, and I started looking at it too late yesterday with the water board. When I went there, I was able to message the person in charge, and she sent me all the information that was available that they didn't get on the website either. So, so it would just, yeah. But if it's there, my apologies to whoever I offended. But that wasn't meant to be.
I'm Donna. So on our webpage, under Board of Health, we do post the notice, the schedule, and the agendas there, and the YouTube link, so that you can click on the YouTube link and go to it, and all the archives are there. So there is, I make a packet here, so that is one thing that we don't have on the website is the packet itself.
Okay.
But the agenda is always posted within open meeting laws of 48 hours prior to the board. So I have packets, which you came in late and I didn't get up and give it to you, but I have packets here, so you're more than welcome to take one with you today. So I think the only thing you mentioned on there that's not really available to you would have been the handouts that the board has today that you talked about.
Okay, and is there a reason the public can't? So first of all, I found the agendas.
Okay.
But can that packet be attached with the, like agenda link and packet link? Is there a reason we can't see the information that you guys have? Because it really puts the public, and you didn't have it, you weren't showing pictures up here, so we didn't really know. It's really hard to follow along. And you hear this really brief snippet and you're trying to take notes, and then the next thing was said, and I'm like, oh no, I missed what that was. So.
Well, it's something that we can surely talk about and do.
Okay.
So that's a good point to bring up from your
Okay.
perspective. So thank you on that. But the agendas are posted in the
Yes.
webs, and you can go to our YouTube channel and have the history since we start recording them in COVID, doing COVID forward.
Right, and so I guess I'll ask you afterward to show me where that video
I'd
is.
be more than happy to.
But even having an agenda meeting, the minutes from the last time in draft form, so that I could, like if I wanted to watch one section of that meeting, then that would be easy. But right now, if I'm able to access that link, which I found it for 2019 through 2022, I couldn't find them for 2023.
Okay.
But having the agenda would give me an idea of where I need to go in that.
Yes,
So,
we
or
can-
the minutes,
I can
yeah.
show you. So
Okay.
we'll
All right,
talk
great.
about it.
Heather,
And then one other thing you talked about, they'll probably mention about the county commissioners, about the board appointees, and I'll let them discuss it more. This board doesn't make that decision. So that's why we didn't talk about when there would be a final appointment and when that would happen. They have no power. This board right here has no authority or power to vote in a board member. It all happens
Okay.
at the county level, so you guys can.
And some of the counties have there's a ballot that's officially sent out. And then, there's 3 commissioners, 4 counties, there's 12 votes.
Right.
If they hit 7, then whoever that nominee is, they're elected. And usually they're notified, and then the next meeting they're sworn in. And right now, like, I'm from Valley County, we're not gonna look at it, I don't think until the 2nd of November. First
It might have
November,
been the first.
until we can get it on our agenda, because our agendas are slammed until 6 o'clock every night. So it's a matter of having the time to look at it.
Right, and so when all those 7 votes have happened, when does his position, when does that start? When does that term start?
They come back to the district director, he tallies the vote and determines if yes, you are, or no, you're not. If not, then you go back to that county and say you need to get another nominee because this one was not approved, so to speak. But 99% of the time, whoever is nominated is usually elected.
Mr. Chair.
But
So it begins, I will notify, in this case, Chairman Beck from Ada County.
Okay.
And the other few commissioners, but I communicated with Chairman Beck, copied the other two commissioners that in this case, Dr. Furch's appointment to the board has been approved by vote. It will begin effective immediately. And then in his case, he'll serve out the remainder of Raul Labrador's term because it was set up to start so that it's staggered so that you don't have board members, kind of worst case, all 7 going off at the same time. So we maintain that 5-year cycle, and then it's subject to reappointment. So board members can serve as many 5-year terms as their county as approved by the other 3 counties as the current law is written. They can continue to serve additional 5-year terms indefinitely.
Okay, and so the next meeting isn't until December. If he got the 7 votes, or if it's somebody else, whatever you get the word, does their positions start, like their job, they'll start getting like communications then, or does it wait until December 15th?
They'll start getting communications effective immediately. They could attend meetings if we had a special meeting or an emergency meeting. Once they get 7 votes, it's official. Then there's no big process. That's the process. And when they have 7 votes, then they're a member of Central District Health Board.
Thank you.
Well, I think it's really important that the public understands that your county commissioners picks the representative, not this board. So if you get a change in county commissioners, they may have someone else that they want. And so that term could be over with and they appoint someone else new. And then usually the new person, whoever gets it, has to take everybody out for dinner and a big party.
Pretty sure I didn't see that in the budget.
Yeah, oh, that's that little fine line down the bottom. No, I'm just kidding.
Okay. Well, I'm gonna finish with one more public comment, and that is that this is the first time that I've ever in numerous public comments in many, many states, ever had a board interact with me and give me feedback on my public comment. And so I am exceedingly appreciative of that. And I want you to have that feedback because that's a really big deal. It's really hard to contemplate coming here when you think, oh, I'm just gonna be ignored again. And so it actually took a lot of like making a conscious decision to come. So thank you very much. And even though some of it was overkill and so, okay, so thank you.
Thank you.
Thank you, Heather.
Yeah.
Is there anyone else in the audience? Being none, I guess at this time then I will adjourn the meeting. And we'll see everybody when? December 15th.
God bless.
Christmas. Thank you guys. Great meeting. Good day.
Thank you.
And,